And I'd like to welcome our first speaker, who's Professor John Meliones, currently of Duke University, and he's soon going to drop the professor title and become the Chief Executive Officer of Practicing Smarter, a software company. Welcome, John.
Peter suggested that the company name Practicing Smarter was probably not good and that we should change it to Dumb and Dumber. And I said to him, what does that mean, that you're joining me? So today we're going to talk about cardiorespiratory interactions. One of the nice things about cardiorespiratory interactions is it's something that you can do that the surgeons, your cardiovascular surgeons, will have some difficulties with understanding, and they usually go hide, and you can go send them off in there to get some coffee, and you can sit and manage your patient. And there are several times that cardiorespiratory interactions will begin to help us really optimize the patient care and can make the difference in our patient population. What we're going to do today is talk to you about cardiorespiratory economics, looking at the supply-demand. Then I'm going to talk about the heart and lungs, and I'm going to strictly talk about just the physiology of these interactions. Whenever we talk about cardiorespiratory interactions, it's the understanding of the heart and lung and how they work together and how the economics of this are important. We need to understand that oxygen supply is going to be equal to the delivery to the tissues, and it's related to cardiac output times the oxygen content. And that's what we're going to be talking today, is how do we optimize our interaction using the ventilators and other things to try to improve the cardiac output and oxygen delivery to the tissues. Now the demand is, of course, the amount of oxygen used by the tissues. And it's going to be this important relationship between the supply and demand that's important, right? Because if we have inadequate oxygen being delivered to the tissues, then we'd slip into anaerobic metabolism and we have end organ injury. And when one looks in the intensive care unit at the primary cause for abnormal convalescence in the ICU is what? It's an imbalance between supply and demand, and we have a situation where we have inadequate oxygen delivery to the tissues. And that is what we're trying to prevent today. We can optimize oxygen delivery by increasing the oxygen content. We all know how to do this using the ventilators, increasing hemoglobin or increasing our saturation of PO2. But what we're going to spend our time talking today about is improving oxygen delivery by optimizing cardiac output through cardiac and pulmonary interventions. One thing that's also important for us to recognize, in situations where we have an imbalance, one thing we can also do is reduce the demands of the patient by decreasing the work of breathing as well. So let's talk about the heart, and I'm going to talk specifically about the physiology of the cardiorespiratory interactions in the heart and lung. The right ventricle sits in the thorax, and it gets its blood from outside the thorax. And then it must then pump this blood into the thorax. And so anything we do to increase intrathoracic pressure is going to do what? It's going to limit the amount of blood coming into the heart and force the ventricle to push against a resistance. So positive pressure ventilation is usually not very good for the right ventricle. This is described in this slide here, where we look at systemic venous return being low, 0, to its maximum level here, and the right atrial pressure being low to a high level here. When the right atrial pressure is very, very high, for example, higher than the pressure that blood comes back to the heart, because remember, there's no pumping mechanism to get blood back to the heart. It has to pump and flow passively. So if the pressure in the right atrium is higher than venous pressure, then there's no flow back to the heart, okay? As we begin to drop right atrial pressure, then flow and systemic venous return will increase to a point in time where we get the maximum amount of venous return, maximum amount of filling in the right ventricle. And during spontaneous breathing, fortunately, right atrial pressure is low, so there's a luxurious amount of flow coming back to the right ventricle and a luxurious amount of cardiac output. As we increase intrathoracic pressure through mechanisms such as positive pressure ventilation, there's a reduction in flow, and we may get to a point in time where we critically reduce systemic venous return and decrease oxygen delivery. And this is probably the most dominant component of cardiorespiratory interactions that we're going to talk about, is the effects on right ventricular filling. So if we increase intrathoracic pressure, you may decrease cardiac output by doing two things. One, decreasing right ventricular preload, or two, increasing pulmonary vascular resistance. So the best strategy for the failing right ventricle is to limit the intrathoracic pressure. Now what about the left ventricle? Now the left ventricle is different, right? It sits in the thorax, it gets its blood from inside the thorax and pumps outside the thorax. So it's different than the right ventricle. And the physiology and approaches we use for RV dysfunction should not be the same for LV dysfunction as well. This is a situation here where we see positive pressure ventilation. If we have blood in the lungs, increasing positive pressure ventilation can actually augment LV filling. Thoracic augmentation of left ventricular filling has been shown to be effective in certain clinical situations where you have abnormalities of LV filling. If you have a lot of LV diastolic dysfunction, then one could potentially augment filling in the left ventricle by positive pressure ventilation. So we're seeing sometimes positive pressure ventilation is bad for the heart. Sometimes positive pressure ventilation may be good for the heart as well. What about the effects on afterload? If we're trying to generate a pressure here of 100 in the aorta, okay, and we take a big negative intrathoracic breath, something like an asthma, patient's got a negative intrathoracic pressure of -30, then one must generate a pressure in the LV of 130 to actually transmit that 100 to the aorta. Okay? Pulsus paradoxus, for example, is the inability of us to generate this 130 pressure, and so we generate less pressure, and we see less pressure distally in the aorta. Now, with positive pressure ventilation, if we phasically increase positive pressure ventilation, we have an increase in intrathoracic pressure, so now the LV needs to generate as much pressure, and this is transmitted to the LV and transmitted to the aorta, so the transmyocardial pressure that the LV requires is now much less during positive pressure ventilation. What this is essentially saying, complicated stuff, bottom line is positive pressure ventilation may result in a reduction in LV afterload and may be potentially beneficial in certain conditions. Now, these effects are very important when we start talking about if I have a pressure in my ventricle of 120 and we put on a peak pressure of 30, so what? It's only about 25% systemic pressure. But if you take a baby, a neonate, who has a pressure of 60 and put a peak pressure of 30 in there, what's that? That's 50% systemic pressure. So that's why these effects are so important for us, and that's why the adults talk about this somewhat, but we should be talking about it a lot more because these effects can be very, very dramatic in the small baby. So increases in thoracic pressure may cause you to have nystagmus, may increase LV preload when it's low. It may decrease LV preload when it's excessive. Remember about the LV effects. There is no free lunch. So if you're trying to improve LV filling by giving you thoracic augmentation, what are you going to do? You're going to hurt the right side because you're going to increase mean airway pressure. So there's no free lunch here. Mean airway pressure, people talk about this as, oh, I've done this and this has helped out. The mean airway pressure has worked really well by improving LV filling. But remember, there's a downside to it. The downside is on the RV side. So let's talk about the lungs now and the pulmonary vasculature, the effects on the pulmonary vasculature. This is an example of lung volumes and pulmonary vascular resistance. And what we see with these lung volumes and pulmonary vascular resistance, at the lower end of lung volumes, there's atelectasis and hypoxic pulmonary vasoconstriction. Maybe I should do this without slides. And during this low lung volume, there's hypoxic pulmonary vasoconstriction, and then you get increased pulmonary vascular resistance. Forget looking at the slides. It's making me dizzy. At higher lung volumes, what happens? We overexpand the lung, and the capillaries become compressed, and we increase pulmonary vascular resistance. So the extremities of lung volumes we need to be careful about because both of them will increase vascular resistance and hurt our RV output. So pulmonary overdistension can decrease pulmonary compliance at termination of mechanical breath. This is something that's very important for us to watch for and look for. This is a pressure volume loop, airway pressure, volume, and we see at the end of this breath there's overdistension. We're trying to put more volume in this than the alveolus can accept, and this happens not infrequently during mechanical ventilation. Many times when I'm traveling around and asked to look at a patient, we'll see these patients who have pulmonary overdistension. And this is a significant problem because not only can it cause barotrauma, but it's going to cause an increase in pulmonary vascular resistance. Overdistension causes barotrauma, but from a cardiovascular standpoint, it will increase RV afterload, increase pulmonary vascular resistance, and therefore potentially decrease cardiac output. And here's some work where they looked at the effects of tidal volume on cardiac output at different levels of PEEP. So these effects, as you've increased the PEEP and increased the mean airway pressure and overdistended the alveolus, as you begin to increase your tidal volume, the effects are more dramatic with the higher levels of PEEP. You see with PEEP level of 5, pulmonary overdistension causes a reduction in cardiac output. And with a PEEP of 10, you have a very dramatic reduction in cardiac output here as well. Look at pulmonary vascular resistance. Again, a PEEP of 10, dramatically increasing pulmonary vascular resistance, demonstrating that pulmonary overdistension can be a very significant problem resulting in increasing in afterload. One of the other things that we need to understand is that ventilation and alkalosis can lower pulmonary vascular resistance. make a pig hypoxic, and then you do a respiratory or a metabolic alkalosis, and this will reduce pulmonary vascular resistance. This is important for us to note because people are still trying to hyperventilate patients to lower their pulmonary vascular resistance. Hyperventilation is not the way to lower pulmonary vascular resistance, okay? The reason why that isn't is it causes an increase in mean airway pressure and also decreases CO2 and can cause you to have decreased cerebral blood flow. In conditions where we have low output already, this is not a good thing. So what you need to do is create a metabolic alkalosis. Like in this slide right here, we look at the CO2. Here's the CO2 in this slide, the region right here, a decreasing CO2 and an increasing CO2. And here's the pulmonary vascular resistance going up and going down. Let's concentrate right here. What do we see? We've reduced the CO2 by around 30%, and what's happened? There's been no change in pulmonary vascular resistance. Why? Because we've kept the pH constant. So it's really the hydrogen ion that causes the problem. Now, it's important to remember that people say, well, what about increasing the CO2? We use that for hypoplast sometimes, for example, to increase pulmonary vascular resistance. Well, yes, if you increase the CO2 and allow the CO2 to go up, there will be an increase in pulmonary vascular resistance. So you don't want the patient to be hypoventilated. You want them normally ventilated, but you don't need to hyperventilate the patient because there's several significant negative effects of that. We want to try to avoid that. So what are we going to do with the pulmonary vasculature? We're going to optimize the lung volume. We're going to avoid overexpansion, but we're also going to avoid atelectasis. Remember the old days when we had brain-injured patients? We said, don't put them on any PEEP. Put them on 0 PEEP. Okay? Well, 0 PEEP may not be the right thing because it's only 2 in mean airway pressure. It may not cause us to change in any cerebral perfusion pressure, but it may cause atelectasis and hypoxemia and increased pulmonary vascular resistance. So we want to avoid hypoxic pulmonary vasoconstriction. We want to avoid hypercapnia. Yes, promote an alkalosis, but use a metabolic alkalosis. And now remember that neonates are at increased risk for pulmonary hypertension, and we can use a lot of different agents. We have a window to the pulmonary vasculature, which is wonderful because of the endotracheal tube, and we can take our advantage of that as well. So what we've talked about is the economics of the heart and lung interactions. We said that it's important to balance the amount of oxygen you're delivering to the tissues with your consumption, and that if you have an imbalance between delivery and consumption, that's the #1 cause for abnormal convalescence. We talked about the cardiorespiratory interactions. We said the right ventricle gets its blood from outside the thorax and pumps it into the thorax, and it'll be very sensitive to changes in mean airway pressure. We said the left ventricle may actually benefit by some positive pressure ventilation, but you have to be careful about the downside effects of that on the right ventricle. And we talked about the lung. We said optimum lung volume, get the lung open, keep it open, don't let it collapse, don't overexpand it, however, and also don't allow to have high CO2s. Thank you very much.